Thanks so much for having us. And this is a very important topic in regards to engaging MAT patients into services. So interestingly enough, as we embark upon this conversation, I think the most important component of engaging patients is actually treating patients. Not looking at predetermined treatment models, individual opinions, and we really look at the needs of the individuals, their families, and exactly what's going on in their circumstances. Determine what treatment model works for them, what medication works for them, and we initiate that based on the individual needs. Then we can have a conversation about true treatment and recovery. One of the areas that we've been successful is community relations and partnerships. Those of you who have heard before, we have a program that initially started off as a navigation program that we've expanded into phases. Initially, our navigation started off as a satellite relationship with the community hospital. That expanded into our hospital pilot, in which our peer and our addiction nurse specialist have touched approximately 500 lives. And from there is moving into our OUD project and our ED induction project, where we are actually moving patients from an inpatient level of care into our services and treatment, inducting them and continuing them on their antibiotic treatments that they need for 6 to 8 weeks for that endocarditis and systemic infections that is as a result of their IV drug use. At the same time of working on that, we're working with one of our new doctors who's a champion in some of these ED inductions. So ideally, when these individuals hit the ED, that they're actually engaged immediately into services. Our peer recovery specialist and addiction nurse can meet them at the bedside, start talking with them about services and what we can do for them, and start that process of induction, and then once stabilized, moving that individual into our services and continuing on those antibiotic treatments if needed. So we've been very successful. We've received about 6,000 from 2015, remember, 6,000 referrals, placing about 75% of those into our continuum. Our peer recovery specialists have touched about 500 lives. And of those, we've moved about 5 of those OUD project. These are people who are on antibiotic treatment services for 6 to 8 weeks, into our services and into residential treatment while they continue their antibiotics. The other part of that phase that just initially started is with our local sheriff's department, who currently has in the field officers that are working as a project and sending us direct referrals through that navigation and peer recovery specialist into services directly from the field, and we will actually meet those patients at the hospital. So when you look at engagement, it's really looking at removing barriers and meeting the patients where they're at, regardless of where they're coming, whether they're coming into your facility, whether they're coming to the ED, whether they're running into law enforcement, meeting them where they're at and engaging them and moving them into service with a warm handoff. Again, that looks different for every single patient. There isn't one service that works better for another. It's looking at the patient and looking at their individual needs and making recommendations based on that.
Hi, everyone. So for Operation PAR, can I just get a show of hands for how many of you are part of an agency that is a federally licensed OTP that can offer like methadone maintenance? Okay. So a few of these things are going to be applicable to you, but in the larger scheme of things, as far as engaging new patients who have opioid use disorder into treatment, one of the big things is try and not narrow your options too much to the point where even though this individual who says, I've been shooting up with heroin frequently every single day, and you might think, okay, well, the best option is going to be methadone treatment for this individual. And then they say, no, I don't want to be on methadone. And you say, all right, buprenorphine then. They said, no, I don't want to be on buprenorphine. And rather than thinking, well, you know what, we just need to change your mind because we're certainly not going to offer you Vivitrol, really come down to something is going to be better than nothing. So if that patient is willing to engage in something, then take what you can as far as getting them engaged in treatment. Because the longer that you have them engaged in treatment, maybe you can change their minds if the need arises. Now, of course, there's safety considerations. Maybe you want to stick with the daily naltrexone instead of switching over to the Vivitrol initially. But so there's that. As far as getting additional patients to be referred into treatment, it's community engagement. So, between me and our clinical director, Mike Osborne, here, we provide free educational trainings to everyone in the community that we possibly can. So agencies that would probably end up seeing patients with opioid use disorder, specifically hospitals, criminal justice system, and educating them about medication-assisted treatment so that they're much more likely to refer patients to us, rather than looking at us like we're the black sheep, like they don't even want to acknowledge, hey, we're not going to send someone to a methadone clinic, we're not going to put them on another drug, things like that. We also have, engagement in the emergency room with a peer. One of our peers for St. Anthony's, we have Ken here, and the idea is that, through shared experience, you have individuals that aren't willing to really talk to physicians or anybody else because they don't think they understand what's going on with them. If you've never actually been addicted to any sort of substance, then why should I even listen to what solutions that you might have to offer? And so that's hugely important. If you can actually engage with local hospitals, trying to get a peer in there, really, or anyone for that matter, in there, or getting people on your side as far as physicians, trying to educate them. You would be shocked at how many health professionals have no knowledge at all, or really the wrong knowledge, false information about medication-assisted treatment, and they've sort of, brushed it off their shoulders like, oh, I don't really need to engage in this sort of thing. Once you do get them in the door, making it as easy as possible and reducing delays for admission is hugely important. One of the things that we've been trying to do lately is streamline our admission process to the point where same-day admission, if a person comes in and they meet the criteria for treatment, we want to get them face-to-face with our physician that day, where they would receive their first dose of medication that same day. And this can be very, very difficult, especially if you have limited providers who can actually admit new patients. But it makes a lot of sense if you start looking at some of your outcome data, where how many patients come in, they get screened, and then you schedule them for an admission several days later. How many actually show up for that appointment? Because it might have just been a very fleeting moment where this patient was willing to engage in treatment, but when you tell them it's going to be 3 days before we can actually start you, what are they going to do for 3 days? They're going to end up using, and big likelihood that they're not going to show up. The other thing is for patients who need to be readmitted, making less restrictive readmission criteria. One of the things that we've sort of evolved through Operation PAR is the idea of positive drug screens, for the most part not resulting in somebody getting tapered down off of their medication and referred to a higher level of care that, quite frankly, is inaccessible to most people. Where at this point, it's alcohol and benzodiazepines where the physicians might discharge patients as a result of that because they don't want to contribute to a potential overdose. And it's a tough position to put them in because of how litigious our culture happens to be. But for patients that end up getting discharged for, let's say, benzodiazepine or alcohol use, to make it so that it doesn't necessarily require complete abstinence for them to be readmitted. Just some sort of step in the right direction would be what I would strongly encourage. And this is the transition that we're trying to make right now at PAR. Other than that, of course, there's marketing, which I think a lot of treatment providers might not be specialized in, but it is important to actually get the word out there about medication-assisted treatment, the fact that you offer it, things like that. That's it.
I think they both actually said it very well. I could echo them both. The one thing that that they haven't mentioned that we do at PAR Place, on top of the integrated health care practices, meeting patients or clients where they're at, peer support specialists planted in EDs, We also are in the criminal justice system in the jail, but we have implemented telepsychiatry, telehealth services to help break down some barriers too. Engagement is all about breaking down barriers. If you have something in the way preventing you from achieving your goal, engagement is going to be hindered. So we do understand, as he mentioned, that sometimes you don't have enough providers available to engage people quick enough. And that could be, those hours, those days could be the time frame, that's all that's needed. But if you don't have to move a physical body, if you can zoom somebody in on a TV screen and tie into a detox or into a residential unit to do the medical evaluation necessary to get labs done and things like that to move those individuals to the next level of care, you can do that instantaneously with telepsychiatry. And those services have been absolutely amazing to engage people at all levels of care. So I'll leave it at that because everything else they said was, hit it on the head.
So the question is anybody having difficulty time engaging patients, and what are you all doing to get them engaged? Or are you using strategies different than what have already been mentioned up here? Some dialogue, some questions. So let's ask the question, is there anybody in here that does just Vivitrol and does not do buprenorphine? So that's what I thought. Most of the people that were in the survey who are here do both of those medications.
So one of the best stories that I've come across recently was a patient was given, when they came into the program, the Narcan kit, and that kit ended up saving one of their friends' lives. That person came into treatment, and that was just a huge, wraparound. We recognized at PAR that there was an opportunity while people were in the lobby, sometimes waiting in line for their medication, instead of looking at a TV with the weather or Jerry Springer, to maybe put some information on there about buprenorphine, Vivitrol, and how those medications work, in case they wanted to consider another option, or just, there was family members sitting there with some patients getting some education. Otherwise, maybe they wouldn't have gotten that. So there are some opportunities, I think, that you can engage people in.
So that's a good question. How many people in their waiting room have a TV where they're running information about the 3 medications? Does anybody have that? PAR does. Anybody else? So in what Uda's question was, one of the things that's important to the agency is that all patients understand that there are these 3 medications, and if you don't offer one of the medications, then how do you refer somebody? Like, for instance, many of you don't offer methadone. So if you don't offer methadone, how do you say to somebody, you might be appropriate for methadone, and how do you make that referral? That's the question. Anybody want to comment on that?
I will. So what we do is as a methadone provider, we contact other non-methadone providers and try and educate them about using a screening tool, which, not to try and steal their patients, but methadone is for more severe opioid users in general. Just because the buprenorphine has that ceiling effect, it might not be strong enough to take over all of the withdrawal symptoms that they might have. But just making sure to educate them and let them know exactly what the referral process is, trying to make it as simple as possible. For us, it's just send them to us and we'll take care of it. You don't need to fill out a form or do anything. Give us you could give us their number if they sign a release, or give them our number, whatever you want to do. But if they just walk in the door unscheduled, then we'll be able to take care of it. But just trying to make sure that you keep in contact with those local providers who don't provide methadone treatment, because they might look at it like, if buprenorphine didn't work, then higher level of care, and hopefully they can afford it. But when in reality, methadone might be the most appropriate option.
I think what you keep hearing repeatedly throughout the conversation is the community relationship and partnerships, and the ability to reach out and connect with each other. So maybe Aspire does all 3 medications, and we screen to see what meets the need of the individual. But in the event that someone who just did one of the medications, such as buprenorphine, or only did methadone, we want to extend that warm hand to say, look, if you have a complicated case and you need assistance, maybe we have an option that may be of better benefit to the individual, and being able to have that open conversation, because we're really not arm wrestling for patients. We have plenty, more than what we can actually really take care of. So having those relationships with the EDs, with law enforcement, with the corrections division, with our primary care physicians, so that we're having this dialogue. I look back 5 years ago, or even 10 years ago, we would have never been in this room with all of the disciplines having a conversation about how we communicate and take care of people with opiate use disorder.
A lot of times in the emergency department, and I don't know if I missed this when we were late, and I apologize, but a lot of times in the emergency department, we don't get an acceptance immediately. And I always feel like that's an amazing opportunity to give true harm reduction education, safe injection practices, and then educate them on how to do Narcan. And we say, if you're not ready for recovery, or you're not ready for these medicines now, here's this strategies on keeping yourself clean, keeping your needles clean. We actually have handouts to educate them on that. And I wondered, if those opportunities don't present when they're actually at the clinic for them to accept the medications, do you offer Narcan and harm reduction strategies? It basically shows them that we care about them, and that just because they're not choosing the option we're giving them, we're not paternalistic, and hey, you can return whenever you want, there's an open door policy. That's what we're promoting in the emergency departments.
Yeah, so we do offer the harm reductions. We distribute and dispense Narcan to each one of the patients, whether they are in our residential level of care, IOP, outpatient, and inpatient detoxification. We also are engaged right now in a research study for some of those clean needle programs and disseminating information in regards to that. Again, it really depends on who you're having conversations with and where you're trying to provide that information, because there's lots of opinions on that as well. But absolutely, this is what this model is all about. It is all about harm reduction and how do we get them to where they need to be.
I'd like to ask an honest question. Is everybody here, who's familiar with the Marchman Act? Okay. Who has actually Marchman Acted a patient or a client? Okay. Who is afraid of Marchman Acting a client? Why?
I have a whole position statement on the Marchman Act, specifically as it pertains to opioid use disorder. And the Marchman Act actually in Massachusetts has been proven to, those patients that have been Marchman Acted in Massachusetts have been compelled into treatment, actually have a higher risk of fatality when they exit. So I have actually been going around trying to educate legislators on not making the Marchman Act a more liberal application of the Marchman Act. The Marchman Act, I think, is a two-edged sword. I think for very specific patients, it's probably can maybe be beneficial or possibly make an intervention that could save somebody's life. But I think at the point where it infringes upon, a patient's autonomy and rights, and then where they go after that compelled treatment or what they do after it, that worries me as a physician.
The Marchman Act, in my opinion, is a tool to engage people in a treatment if they put themselves at risk or others at risk. And I think a lot of, especially ED departments, have the same opinion you have, which I'm trying to help educate them on. The most acute level of care, where a lot of people end up, probably because they overdose or rushed, is to a hospital. Anybody who overdoses has already put their life in jeopardy. They have already met the requirement of a Marchman Act. They were unable to make proper decisions for their own life. And we have ED departments that will quickly help them withdraw, medically manage them, and send them back out into the community. But they're unable to make those decisions. You may help them get on an MAT, which could increase or decrease their tolerance in some way or another, but it's not going to help them overcome their addiction. The recovery is a process. It is a process, and engagement is in the process. No MAT is a magic pill or injection. None. Because at any point in time, somebody can just decide to not come get their next injection or be compliant with their medication. They may get angry. They may have learned to develop a cognitive structure that when they get upset, that emotion will override anything, and the impulse to use comes into play, even if they're on their MAT. There are people that try to override the mechanism and overdose doing that. Engagement has to be in the whole concept. It's a process. So you have to have wraparound services. We engage them at MAT level of care, at hospitals, at Department of Corrections, at our withdrawal management, detoxification centers, in communities and households with families. But not only engage them with that, we engage them with therapy, we engage them with peer support, we can engage them with case management. We integrate those services with other community health agencies. If they move, we set them up. I think there is...
For all patients?
Every patient that comes through our door, that's our intention. That's what we try to do.
Because part of my argument to be hesitant of expanding the use of Marchman Act in this patient population is that if I Marchman Act a patient, I want them to get the gold standard care for that patient. If I Marchman Act a patient and that patient goes into a 10-day detox program, I've just educated you all on what my opinion on a 10-day detox program is. So I'll be, you will not press me to do that patient harm, in my opinion. Yes, you're saying that they could be at risk for losing their life because they've lost control of their addiction. Absolutely. But I am also not going to do harm to that patient by instituting substandard care for them through use of the Marchman Act. If we have full, like you're explaining, holistic care and such, and all of the services that should be available to those patients, many of those patients are indigent, that the families come to me to ask to Marchman Act them, and they're going to get the bottom of the barrel treatment program. And I just have an ethical issue with that. My personal opinion is any treatment's better than none, number one. Number two, I think a lot of what FADAA is doing, a lot of what the state legislators are doing is trying to help community agencies develop the holistic practices that we've worked hard to create. We didn't have funding for peer supports. We didn't have funding for 20-bed detox. We pushed and fought for this as the epidemic got worse and helped develop this community of practice. What you need to understand is that the Marchman Act at your level, at the physician level, is going to be a physician certificate, right? That means that you're recommending them to be evaluated and stabilized, technically. So if they come to a receiving facility such as Aspire, I'm not sure if PAR is, they're going to be evaluated there, at which, if they agree that they should then go through with the Marchman Act, then they will go to court. Now, I'm not sure how anybody else does it, but at Park Place, in Osceola County, we've instituted telecourt. Our individuals are detoxed in 3 to 5 days, especially if they're coming from the hospital where they might have already been partially or fully detoxed. So we can actually get them to meet the judge if they meet the requirement to actually go beyond the assessment into actual Marchman Act territory, where they will sit in an office with a therapist, the court liaison, and the judge on the other end of the screen before they go back out into the community, so they don't have that period of time where they could potentially relapse, where we can engage them in treatment immediately. These are all R&D that we're trying to work on in regards to what does it mean to effectively cover those gaps, give them the best gold service we can with the resources we have, and working in tandem with the physicians in the ED, because if we're not able to help support you, what are we doing?
Right? What are we doing?
One of the things that I don't think I think we don't pay enough attention to is the fact that every community does not have a robust network of care, and they don't have a robust network of care in the public space. And then some communities don't really have other options than whatever is in the public space. If you have money and resources, you can go other places. And I had a conversation in the room a few minutes ago about insurance that refuses to pay for medication-assisted treatment, about health plans that refuse to pay for medication-assisted treatment. And that's a huge public policy question, because the reality is, if you have insurance, it should cover care. So at some point, there'll be the right case, and somebody will take that to court, and that's what the lawyers that are working in the parity space nationally are looking for. They're looking for those right cases so they can take them to court, get the rulings, which will then force the insurance companies to get rid of pre-approval and get rid of artificial limits around medication-assisted treatment. Because one of the things that NIDA, SAMHSA, CDC is all promoting is, if you need the medication, you get it. You have immediate access to the medication. And I forget what state just did that. And I know Massachusetts does it. I think it was Ohio, that you get immediate access. New Jersey just passed legislation that says you can't deny somebody from a medication-assisted treatment if they have an opioid use disorder. So that's the kind of legislation we need to be promoting in Florida. That's the kind of legislation we need to get all these legislators, and we all have to rally around the same plan, that this is what we need. If we really want to affect this, we have to not give the option to the insurance companies, but require the insurance companies to make that available.
I just wanted to quickly say, so for those of you who are receiving facilities for the Marchman Act, can you just raise your hand if you're part of an agency? So if you get a Marchman Act that comes in from an opioid use disorder, or they qualify for opioid use disorder, are they offered MAT while they're in that 3-day Marchman Act period? Okay. So I think, reasonably, as long as that there's some sort of reasonable assurance, I would say that seems fine to me. But again, like Dr. Wolf said, if you're going to set them up to detox, then that's setting them up potentially to overdose and die.
In regards to the Marchman Act, we have a very large continuum of care. We see approximately 45,000 patients a year, so we are fortunate. We do have that gold standard of care. However, I'm not exactly sure what gold standard of care looks like in regards to opinions, because it really depends on what the patient needs. Because not every patient needs detoxification for stabilization, for induction, then residential, then PHP and IOP and outpatient, all of that. So we really have to look at what that looks like. I've seen the Marchman Act work really well, okay? But it really takes the connection and the relationship with the ED and the addiction receiving facility so that that information is transitioned, so that when we petition the court on behalf of the hospital, we have the information that supports court-ordered mandated treatment. And if they are being received at an addiction receiving facility, they are actually being held by a court order. You can restrain them. You can lock them in a facility. Now, if they're going to an outpatient that is not at an addiction receiving facility, you cannot hold them, you cannot put your hands on them.
Most of the detox, which are not
So, but the Marchman states that it should be received by an addiction receiving facility unless there is not reasonable accommodations within a reasonable area.
And then just lastly, I'm just making each point for these are my talking points as they pop up in my head, truthfully. And then lastly, if you look at the literature on compelling OUD patients to treatment, it is absolutely equivocal and actually, again, leans towards you're at higher risk for an overdose when they leave the treatment.
I absolutely agree in regards if you are just inducing and inducting a detox. But when you're looking at what we're looking at as a best practice, we all know if we're just going to enroll everybody in detox, how often does detox work? How many times those of you who have detox have seen the same patients, know them by name, and actually could probably give the whole history to the ED doc when they call you?